Cardiothoracic Surgery Part 1 Chest Injuries Etiology and Mechanisms of Injury Blunt trauma, penetrating trauma, and blasts. Blunt trauma, crushing of the chest wall. Examples: blows to the chest wall, fall from height, and motor car accidents. Penetrating trauma. Examples: by stabs or missiles. The kinetic energy of the bullet is proportional to the m times v power 2. Damage caused by gunshots is more dangerous than pistol shots and more dangerous than stabs. Blasts. The blast wave disrupts the alveocapillary membrane, leading to hemorrhage and leakage of interstitial fluids into the alveoli. Presentation: dyspnea and cough with frothy blood sputum. In addition, the produced missiles from an explosion may cause blunt or penetrating injuries. Consequences: fractured ribs, hemothorax, pneumothorax, lung injuries, cardiac injuries, injuries to the major blood vessels, diaphragmatic injuries, and esophageal injuries. Incidence: 20% of all trauma victims. Chest trauma, especially within the box area, nipples to mid-clavicular points, can be fatal in polytrauma if not prioritized and dealt with. Most chest injuries, blunt and penetrating, are managed by intercostal tube insertion. Thoracotomy is seldomly 10% indicated. Shortness of breath with hypoxia is the most immediate threatening feature. Interventions must ensure adequate ventilation and oxygenation. Causes of respiratory insufficiency: depression of respiratory center due to head injury or narcotics, airway obstruction by foreign body or secretions, unstable thoracic cage, for example, flailed chest, lung collapse due to hemothorax or pneumothorax, pulmonary contusion or laceration, and finally, diaphragmatic rupture. Management: following the principles of Atlas, ABCDE, in primary survey, 5 major thoracic problems are life-threatening: tension pneumothorax, open pneumothorax, massive hemothorax, flail chest, and cardiac tamponade. Tension pneumothorax: insert needle in the second intercostal space. Open pneumothorax: seal the wound by an adhesive dressing which is fixed at 3 sides. Massive hemothorax: resuscitate, then insert an intercostal tube. Flail chest: stabilize the flail segments by cotton gauze and compressive bandage. Cardiac tamponade: pericardiocentesis, and this causes temporary relief. Proceed to secondary survey and perform meticulous chest examination by inspection for any wound and assess chest expansion, palpation for tenderness, subcutaneous emphysema, and assess the position of the trachea. Percussion: the note may be impaired, lung collapse, dull hemothorax, resonant pneumothorax, or tympanic, which is tension pneumothorax. Auscultation to assess air entry. A stab wound or a bullet injury to the lower chest may also cause an abdominal injury. In chest injuries, the most common cause of death is respiratory insufficiency, which presents mainly by restlessness and agitation. The surest sign to diagnose hypoxia is to do ABG. Rib fractures. Etiology: direct violence, indirect violence, muscular violence. Direct violence: examples, blow or crush. Effect: visceral injury, as the broken ends are driven inwards. In severe crushes, several ribs may sustain double fractures. Depression of the fragments and paradoxical movement, which is called also flail chest. Indirect violence: examples, compression of the chest, leading to bending of the ribs beyond their natural elasticity, giving away at sites of maximum stress, usually at the angle. Visceral injury is uncommon, as broken ends are driven outwards. Muscular violence: examples, during violent sneezing, coughing, or lifting a heavy weight. This may cause fractures of the anterior segment of a rib. In old people, this is called senile osteoporosis. Simple rib fractures: clinically, symptoms, pain, signs, tenderness, and possibly cryptus at the fracture site. Complications: limitation of respiratory expansion by the pain, leading to atelectasis and pneumonia. Undetected underlying hemothorax or pneumothorax, which is lethal. Fractures of the first or second ribs leads to injury of subclavian vessels or brachial plexus. Fracture of lower ribs leads to liver or splenic injuries. Investigations: plain chest X-ray to detect any air or fluid collection. Treatment: relief of pain to allow adequate lung expansion, strong analgesics such as pethidine and NSAIDs, intercostal nerve block or epidural analgesia for persistent pain, chest physiotherapy, mucolytics, and expectorants. Flail chest definition. 3 or more ribs are fractured at 2 points due to crushing injury of the chest. Integrity of chest wall is lost and flail segment moves paradoxically. During inspiration, the flail segment retracts, while on expiration, the flail segment bulges. Effect. Limits the patient's ability to create enough negative intrathoracic pressure to ventilate the lungs, and this interferes with respiratory efficiency and leads to sputum and carbon dioxide retention. Side-to-side movement of the heart and mediastinum leads to mediastinal flutter, and this interferes with venous return. Usually, it has underlying pulmonary contusion or laceration. Treatment. Relieving the pain by strong analgesics, intercostal nerve block, or thoracic epidural analgesia. Initial stabilization by cotton gauze, plus compressive bandage or elastic chest belt. Encourage physiotherapy. Endotracheal intubation and mechanical ventilation using PEEP is indicated in combined head injury causing disturbed or lost consciousness, tachypnea, respiratory rate exceeding 35 per minute. The oxygen in the arteries is less than 60 mm mercury, or the carbon dioxide pressure in the artery is more than 50 mm mercury or equal to it, and the age is more than 50 years. This internal pneumatic fixation acts as a pneumatic matrix which supports the flail segment until provisional healing occurs. Internal fixation of fractured ribs by stainless steel wires or special nails is only done if there is an indication for thoracotomy. Bleeding from lung laceration is not perfused because the pressure in the pulmonary circulation is low, and when the lung is compressed by hemothorax, bleeding vessels are compressed as well. Only 10% of cases, bleeding is from the pulmonary circulation. Hemothorax etiology, we have traumatic, postoperative, and pathological. Traumatic examples, closed or penetrating injuries. The source of bleeding, intercostal or internal mammary vessels. Postoperative, following cardiac, pulmonary, and esophageal operations, or following insertion of a central venous line. Pathological, tumors of the lungs, pleura, or mediastinum, leaking thoracic aortic aneurysms. Pathological sequelae, the respiratory and cardiac movements, leads to defibrillation of the blood, so it remains fluid. In some cases, the blood may clot, and this leads to difficult aspiration. Blood in pleural space is irritant, and this excites the formation of effusion. In neglected cases, fibrin deposits on both layers of the pleura and is transformed into a fibrous layer, leading to fibrothorax. Lung collapse and chest wall deformity occur, and this leads to crowding of the ribs. Blood is an excellent culture medium, and infection is very common. In traumatic cases, associated pneumothorax occurs, and this is called hemopneumothorax. Sternal fracture etiology secondary to deceleration injury of a car driver not wearing the seat belt. The steering wheel hits the sternum, and its presence raises a suspicion of serious intrathoracic injuries such as myocardial and pulmonary contusions, plus the rupture of aorta and hemothorax. Clinical picture of the hemothorax, again, chest pain and dyspnea. Clinical picture of hypovolemia, chest examination, evidence of fluid in the pleural space by finding diminished lung expansion and dullness on percussion. In massive hemothorax, mediastinum is shifted to the opposite side. Investigations. Plain chest X-ray. If hemothorax is less than 500 milliliters, obliteration of costophrenic angle is shown, while if hemothorax is more than 500 milliliters, an opacity rising to the axilla. Hemopneumothorax, a transverse air fluid level and lung collapse. Intercostal aspiration reveals blood. Free flow of non-clotting bright blood denotes excessive hemothorax. Treatment. Aim. Drain the blood as early as possible to allow full lung expansion and avoid the harmful effects of hemothorax. Method. Insert a venous cannula and correct hypovolemia. If there is pain, analgesic is prescribed. Definitive treatment is by insertion of a chest tube in the fifth intercostal space in mid-axillary line, then it's connected to underwater seal to drain blood and follow up its amount. Signs of improvement: the patient is stable, the amount of drained blood is decreasing, and the lung is expanding. Remove the tube if there is no more drainage and the lung is fully expanded. Indications for thoracotomy: early indications and delayed indications. Early indications: bleeding more than 200 milliliters per hour for 3 successive hours, drainage of more than 2,000 milliliters of blood after insertion of the tube, chest X-ray revealing complete opacification of the whole hemothorax or wide mediastinum more than 8 centimeters, associated with injuries such as esophagus or cardiac tamponade. Delayed indications: clotted or loculated hemothorax diagnosed by failure of the tube to drain blood, mini-thoracotomy for evacuation of blood clot, and in presence of foreign bodies, or fibrothorax needs thoracotomy and decortication of the lung. Pneumothorax. Etiology: traumatic, spontaneous, and iatrogenic. Traumatic: blunt or penetrating injuries of the chest. Spontaneous: rupture of emphysematous bulla, solitary lung cyst, or cystic lung. Rupture of a small subpleural tuberculous cavity, and in this case, there is underlying pulmonary TB, which leads to hydropneumothorax. Iatrogenic: positive pressure ventilation complicated by rupture of the alveoli, and this is called barotrauma, during insertion of a central venous line, and injury to the pleura in the upper abdominal operations. Types: simple pneumothorax, open pneumothorax or sucking chest wound, and tension pneumothorax. Simple pneumothorax: a limited amount of air is introduced in the pleural cavity. Presentation: chest pain and slight dyspnea. Examination: diminished air entry and hyperresonance, no mediastinal shift. Investigations: plain chest X-ray showing translucency, absence of lung markings, and the edge of collapsed lung is usually visible. Treatment: if the amount of air is small and no dyspnea, conservative treatment until spontaneous absorption of the pneumothorax. If the patient is dyspneic, an intercostal chest tube is inserted until expansion of the lung becomes complete. Open pneumothorax or sucking chest wound. Etiology: secondary to wound in the chest wall, leads to communication between the pleural space and the atmosphere. During inspiration, air enters into the pleural cavity through the opening, reducing intrathoracic negativity and reducing normal flow of the air through the trachea to the lungs because the chest wall defect offers less resistance to the flow. With large size hole, air completely stops flowing to the lung on the affected side. The mediastinum shifts back and forth with each breath, and cardiac output is reduced, and this is called mediastinal flutter. Diagnosis: clinically by the sound of air going through the defect. Treatment is an emergency. Immediately apply an adhesive external dressing to stop movement of air through the defect, repair the wound in theater, and insert an intercostal chest tube to drain the pleural air. Tension pneumothorax. Definition: a small wound in the chest wall involving visceral pleura or in a bronchus, and this leads to valvular opening which allows air to enter the pleural cavity during inspiration and prevents its exit during expiration. So, gradual lung collapse occurs and mediastinum shifts to the opposite side. Presentation: severe dyspnea due to compression of the opposite lung, and this leads to respiratory arrest. Examination: diminished air entry, hyperresonance, shift of the trachea and mediastinum, and engorged neck veins. Complications: obstructive shock because it prevents cardiac filling, and this is rapidly fatal. Tension pneumothorax is an emergency and there is no time for X-ray diagnosis. Treatment: immediately insert a wide-bore needle in the second intercostal space. Decompression of the pneumothorax occurs. Then later insert intercostal chest tube connected to an underwater seal. Continuous air bubbling through the intercostal tube denotes possibility of a bronchopleural fistula. Thoracotomy is needed then to close it. Lung injuries include lung hematoma, contusion, laceration, or blast injuries. Etiology: impact injuries to the chest wall. Presentation: shortness of breath, hemoptysis. There may be hemothorax or pneumothorax. Suspected with high energy trauma as road traffic accidents, especially with sternal and multiple rib fractures. Investigations: chest X-ray, opacity, hemothorax or pneumothorax, arterial blood gases. Principles of treatment: chest physiotherapy, prophylactic antibiotics, and if arterial blood gases reveal deterioration, start mechanical ventilation. Cardiac injuries. Etiology: penetrating injuries 90% of cases by stabs or bullets, blunt injuries by blows to the sternum or sudden deceleration of unrestrained motor car driver. Tension pneumothorax, massive cardiac contusion and cardiac tamponade cause cardiogenic shock. Neck veins show characteristic congestion in the presence of low blood pressure. Possible consequences: myocardial trauma, contusion with or without a mural thrombus similar to the myocardial infarction, or lacerations healed by fibrous tissue, aneurysm formation or heart failure. Lacerations can cause cardiac tamponade. Rarely, trauma causes rupture of a valve or interventricular septum. Cardiac tamponade definition: accumulation of the blood in the pericardial sac. This causes compression of the heart and impairment in its relaxation and consequently its filling. The rate of blood accumulation is more dangerous than the amount. 150 milliliters of blood may be fatal if they rapidly accumulate. Clinical features: dyspnea, irritability, unexplained sustained tachycardia, Beck's triad, which is congested neck veins, weak or inaudible cardiac sounds, blood pressure which is persistently low despite IV fluids and blood transfusion. Investigations: ECG shows low voltage, extrasystoles, or atrial fibrillation. Plain chest X-ray shows big cardiac silhouettes or flask-shaped heart. Absence of this feature doesn't exclude a tamponade. Fast with sub-xiphoid pericardial window and needed pericardiocentesis. Treatment: for temporary relief, pericardiocentesis or sub-xiphoid pericardiotomy. Pericardiocentesis: a cannula is introduced in the sub-xiphoid area with 45 degrees angle from the skin and 45 degrees angle laterally towards the mid-clavicle. Better done under ultrasound guidance. Definitive treatment: thoracotomy and pericardiotomy for repair of the injury. Injuries to the major blood vessels. Etiology: deceleration accidents lead to thoracic aorta may be injured at the junction of the arch and the descending part. Investigations: plain chest X-ray, a wide mediastinum, CT angiography, and this is diagnostic. Diaphragmatic injuries. Etiology: penetrating chest wounds, this is more common. Compression trauma of the abdomen suddenly raises intra-abdominal pressure and this leads to tear in the diaphragm. Incidence: more common in left side, commonly missed at the time of the accident, usually associated with herniation of abdominal viscera into the chest. Presentation: shoulder pain, diminished breath sounds, audible intestinal sounds on the chest, and dyspnea. Investigations: plain chest X-rays, CT chest. Treatment: repair injury through abdominal incision. Esophageal injuries. Etiology: atherogenic, this is the commonest during endoscopic dilatation of structures, penetrating or blunt injuries to the neck or chest, swallowing of corrosives or foreign bodies, and spontaneous perforation due to forceful vomiting, and this is called Borav's syndrome. Complications: mediastinitis, rapidly fatal if not urgently treated, and septic shock. Clinical picture: acute onset of pain at the site of rupture, acute onset of fever, tachycardia, and hypotension, mediastinal emphysema, and pneumothorax with or without pleural effusion. Investigations: urgent, plain X-ray, mediastinal emphysema or hydropneumothorax, water-soluble swallow, it reveals the perforation. Management of the shock: IV antibiotics and nil by mouth, don't pass a nasogastric tube for the love of God. Cervical perforations: if early, surgical closure and drainage; if late, external drainage and parenteral nutrition. Thoracic perforations: if detected early, surgical repair and chest drainage; if detected late, chest drainage and a feeding jejunostomy, then later esophageal reconstruction. Abdominal perforation: early surgical repair. Empyema or pyothorax. Definition: collection of pus in the pleural cavity. Tuberculous empyema. Definition: tuberculous infection of the pleura may occur as a complication of a rupture of a tuberculous cavity. Treatment: repeated aspiration, anti-TB drugs, and if these fail to allow the lung expansion, then we have to do decortication. Acute empyema. Etiology: root. Secondary to pulmonary infections: lobar pneumonia, this is the commonest, bronchopneumonia, lung abscess, or bronchiectasis. Contamination from a neighboring septic focus, whether ruptures of the esophagus or disrupted esophageal anastomosis. Direct access by open wound, post-traumatic, and post-operative. Causative organisms are pneumococci, this is the commonest, streptococci, and staphylococci, occasionally gram-negative bacilli and anaerobes. Pathological consequences: stage 1, 2, 3. 1. Pre-empyema phase, and there is exudation in the pleura. 2. Fibrinopurulent phase, bacterial invasion leads to heavy fibrin deposition and pus formation. Stage 3, chronic phase, and there is massive ingrowth of new capillary loops and fibroblasts, and this leads to the surrounding of the lung within a thick layer of fibrous tissue called fibrothorax, and the lung cannot expand. Clinical picture, symptoms, history of pulmonary infection followed by pain in the chest with dyspnea, fever, and other signs of severe toxemia, signs of pleural effusion, stony dullness, tactile phrematus, absence of breath sounds. Investigations, X-ray, uniform opacity, tapering towards the axilla. Aspiration, it confirms the diagnosis and allows organism identification by culture and antibiotic sensitivity tests. Treatment, drainage and antibiotics. Drainage, pleurothentesis, introduce the needle one space below the upper border of dullness, then aspirate gradually or repeat if the pus recollects. Intercostal tube drainage, if the pus is too thick or keeps recollecting. Antibiotics according to the culture and sensitivity. Chronic empyema, definition, failure of the lung to achieve total expansion by clinical and chest radiology more than 40 days despite drainage of pleural pus. Etiology, inadequate drainage of pus or failure to recognize and treat underlying causative factors. Clinical picture, general ill health with anemia and clubbing of fingers. Acute exacerbations are common with fever and chest pain. Local, the open type, a chronic sinus in the chest wall leading to pleural and discharging pus continuously or intermittently. Closed type, perforates an intercostal space and subcutaneous abscess or empyema necessitans. In long-standing cases, progressive fibrosis causes contraction and rigidity of the chest wall with crowding of ribs, elevation of the diaphragm, displacement of the mediastinum to the affected side, and finally, sclerotic deformity of the spine. Investigations, lab, bacteriological examination of pus and sputum to exclude TB and to identify the causative organism. Radiological, CT of the chest and chest X-ray to reveal the foreign bodies or underlying lung disease. Treatment, decortication, complete excision of the second pleura, which forms a tight peel around the lung. The freed lung expand and obliterate the cavity. Bronchogenic carcinoma. Etiology. The incidence markedly raised during recent years because of two things: excessive cigarette smoking, both active and passive smoking, and inhalation of irritants such as cobalt dust in mines, petrol fumes in large cities, and silica. Bronchial cancer affects both sexes, and it's commoner in males than females from a ratio ranging from 10 to 1. Occurs most oftenly between the ages of 40 to 60 years, and it has a very bad prognosis. Pathology. Gross types, hilar type and peripheral type. The hilar type is the commonest, 75% of cases. Origin, one of the main bronchi or their primary divisions. Effect, bronchial obstruction with secondary changes in lung as atelectasis, pneumonia, or lung abscess. Peripheral type, 25% of cases. Origin, smaller bronchi, includes Pancoast tumor, which arises at the apex of the lung and invades brachial plexus, the first rib, or the sympathetic trunk, leading to Horner syndrome. Histology, non-small cell carcinoma and small cell carcinoma. Non-small cell carcinoma divided into four subtypes: squamous cell carcinoma, adenocarcinoma, bronchoalveolar carcinoma, and carcinoid. Squamous cell carcinoma from 30 to 40% of cases. Site arises centrally. Advantages: less to metastasize and most favorable for resection. Adenocarcinoma, 25 to 40%. Site arises from peripheral bronchi, frequently discovered incidentally on chest X-ray. Chest wall and pleural invasion are dominant. Bronchoalveolar carcinoma, 5% of cases. Site peripheral, spread to alveoli in other areas of the same or contralateral lung. Carcinoid, low grade and central, plus neuroendocrine activity. Small cell carcinoma, 20% of cases. Site is central. Usually there is massive mediastinal tumor. Spread, direct lymphatic and blood. Blood mainly to the liver, adrenals, brain, and bones. Direct to mediastinum, pleura, chest wall, pericardium. Lymphatic, hilar lymph nodes, then tracheobronchial and lower deep cervical lymph nodes. Staging, T&M staging. Primary tumor, or the TIS, carcinoma in situ. T0, no evidence of primary tumor. T3, tumor of any size invading chest wall. T4, tumor of any size involving hard blood vessels, trachea, esophagus, or presence of pleural effusion. Lymphatic spread in 0, no lymph node metastasis, in 1, metastasis to ipsilateral lymph nodes, and 2 to subcranial or mediastinal lymph nodes. metastasis M0, no distant metastasis, and M1, distant metastasis. And for staging, stage 1, T1, T2, N0, M0. Stage 2, T1, T2, N1, and M0. Stage 3, T3, and N0 to 1, with any T, N3, and M0. Stage 4, any T, any N, and M1. And that's why I wanted to work at the back. Clinical picture: insidious type, acute type, latent type, Pancoast type, and paraneoplastic syndromes. Insidious type, onset is insidious, with a dry irritant cough due to smoking, then asthmatic and associated with hemoptysis, dyspnea, and chest pain. Acute type, onset is acute, with symptoms of pneumonia which fail to resolve satisfactorily or relapses within a few days or weeks. Latent type, in peripheral carcinoma, the disease may remain silent until it's discovered by mass radiography, produce vague general symptoms such as fatigue or indigestion. Distant metastasis, increasing intracranial tension, headache, vomiting, and blurring of vision, pathological fractures, jaundice, and adrenal failure. Symptoms of mediastinal invasion, mediastinal syndrome. Pancoast type, a peripheral tumor at the thoracic outlet, superior sulcus tumor, invading brachial plexus, sympathetic trunk, and upper ribs, lower brachial plexus, lesion with Horner syndrome, and erosion of upper 2 or 3 ribs. Paraneoplastic syndromes, undifferentiated tumors, may produce hormone-like substances such as toxins or antigens, which produce a variety of manifestations. Cushing-like syndrome due to ACTH production, water retention due to secretion of ADH, hyponatremia, water intoxication, and cerebral symptoms. Hypercalcemia due to parathormone-like polypeptide, tender gynecomastia due to ectopic gonadotrophin secretion, carcinoid syndrome due to secretion of 5-hydroxytryptamine or 5-hydroxytryptophan, malignant neuromyopathy, which may cause myasthenia, dermatomyositis, or peripheral neuritis, pulmonary osteoarthropathy, leading to clubbing of fingers. Pulmonary metastasis, origin from any malignant tumor, but they are especially common in renal cell carcinoma, melanoma, osteosarcoma, and carcinoma of the thyroid and breast, plus stomach and prostate. Gross appearance, small, multiple, and bilateral, but sometimes large and rounded, cannonball metastasis. Investigations: radiological, instrumental, and lab. Lab, sputum cytology, presence of malignant cells. Radiological, plain chest X-ray showing coin shadow or hilar opacity or signs of obstructive emphysema, atelectasis, pneumonia, lung abscess, enlarged mediastinal glands, pleural effusion, erosion of ribs, or diaphragmatic paralysis. CT scan, localizing the tumor and detects mediastinal lymph node enlargement, providing high accuracy for guidance of needle biopsy in peripheral regions. Instrumental, bronchoscopy, scalene node biopsy, needle biopsy of a peripheral lesion under radiography, and mediastinoscopy. Mediastinoscopy to biopsy nodes of the paratracheal group. Bronchoscopy establishes diagnosis and assessment of the operability. In 60% of cases, tumor is visible as nodular necrotic mass or irregular stenosis, and punch biopsy can be taken. Signs of inoperability: left recurrent laryngeal paralysis, compression of trachea or widening of carina by enlarged glands, fixity of affected bronchus or malignant infiltration beyond the proximal centimeter of the main bronchus. Scalene node biopsy, it confirms diagnosis and assess operability as well. The pad of fat over scalenus anterior which contained lymph nodes is removed and examined histologically for malignant infiltration. Needle biopsy of a peripheral region under radiography will reveal malignant cells in about 60% of cases. Bronchogenic carcinoma should be suspected in all patients older than 40 years who develop prolonged cough, unresolved or recurrent pneumonia, chest pain, or hemoptysis. Even when pneumonia responds to ordinary medical treatment, the chest should be x-rayed 3 weeks after cure. Treatment: non-small cell carcinoma and small cell carcinoma. Small cell carcinoma, chemoradiotherapy. Non-small cell carcinoma, radical resection in operable cases, which are stage 1 and 2. Stage 1, T1, T2, N0, M0. Stage 2, T1, T2, N1, M0, and I love saying numbers. Radical resection in operable cases, as we have mentioned, pneumonectomy with removal of mediastinal nodes. This is the best treatment. Lobectomy is preferred in elderly patients with peripheral carcinoma. In early stage 3, neoadjuvant chemoradiotherapy may render the case resectable. Radiotherapy is useful in relieving superior vena cava obstruction, bronchial obstruction, and pain of skeletal metastasis. Post-operative pulmonary complications. Predisposing factors, preoperative and operative with post-operative. Preoperative, age of the patient, extremities of age, sex, males are more predisposed than females. Smoking, heavy smokers commonly have chronic bronchitis, excessive production of mucus and damage of cilia, leading to stagnation of mucus in the bronchial tree, and finally dehydration, thick bronchial mucus, and difficult to expel. Operative and post-operative anesthetics, trauma to the tracheobronchial tree, premedication with atropine, prolonged unconsciousness, predisposed to respiratory problems. Nature of the operation, wound pain in the thoracic and upper abdominal operations, interferes with deep breathing and coughing. Abdominal distension due to paralytic ileus interferes with movement of the diaphragm and reduces the vital capacity. Post-operative pain interferes with deep breathing and coughing, leads to stagnation of secretions. Excess use of narcotics interferes with breathing and coughing. Types of complications: atelectasis, bronchitis, bronchopneumonia, lung abscess, pulmonary embolism, Mendelssohn syndrome, ARDS, and post-operative hypoxia. Bronchopneumonia, etiology, sequel to bronchitis and atelectasis. Causative organisms are Haemophilus influenza, pneumococci, staphylococci, Pseudomonas pyocyanis. Pathology, multiple areas of patchy consolidation. Presentation, profound toxemia. Investigations, chest X-ray, multiple areas of patchy mottling. Sputum culture reveals a responsible organism. Prevention, the same as prophylaxis for collapse. Treatment, physiotherapy, and antibiotics. Bronchoscopic removal of secretions may be required. Mendelssohn syndrome, etiology, aspiration of vomitus which contains irritant HCl during introduction of anesthesia in patient with full stomach or intestinal obstruction, or in pregnancy, or in comatose patients after head injury or drug poisoning. Presentation, wheezes, cyanosis, tachycardia, tachypnea, and hypotension. Radiologically, widespread lung infiltration, more on the right than on the left and more in the lower lobes. Laboratory, ABG, showing severe hypoxia. For prophylaxis, all high-risk patients should have nasogastric tube insertion before the operation for suction of the gastric contents. Treatment, bronchoscopic aspiration, steroids, bronchodilators, and antibiotics. Bronchitis, incidence, the commonest post-operative complication, predisposing to severe complications as burst abdomen. It may occur de novo or represents as exacerbation of pre-existing bronchitis. Clinical picture, post-operative cough with mucopurulent sputum, severe suppurative bronchitis. Investigations, chest X-ray is free. And then we have the post-operative atelectasis or pulmonary collapse. Predisposing factors, inhalation of a foreign body or vomiting due to full stomach, inhibition of the cough reflex due to pain or old age and debility, excessive sedation, particularly with morphine, operations on the chest diaphragm or upper abdomen, morbid obesity, lack of mobility, recent stroke. And finally, production of tenacious mucus because of preoperative respiratory tract infection, premedication with atropine, and post-operative dehydration. Pathology, obstruction of a bronchus by a plug of mucus leads to absorption of air distal to obstruction and deflation of the affected area. The consequent collapse may be lobular, and massive. Lobular, collapse of scattered areas throughout the lung. Lobar, collapse of one lobe, usually the lower. Massive, collapse of the whole lung. Atelectasis is a precursor of majority of post-operative chest complications, especially pneumonia and lung abscess. Clinical picture, symptoms, may manifest within 48 hours after operation or pass unnoticed until complicated by serious lung infection. In typical cases, the onset is acute with fever, dyspnea, cyanosis, and chest pain in massive cases. Cough is slight and sputum is scanty and difficult to expel. It may subside within few days with the expectoration of a considerable amount of purulent tenacious mucus. Signs: minor atelectasis producing no local signs, unexplained tachycardia with collapse of a segment or whole lung. The affected side is flattened, immobile, with dullness on percussion and diminished breath sound, and displacement of the trachea and heart towards the side of collapse. As the attack subsides, tubular breathing and coarse crepitations are shown. Investigations: X-ray showing the collapsed loop, homogeneous wedge-shaped opacity, while the major atelectasis, approximation of ribs, elevation of diaphragm, and deviation of the mediastinum towards the affected side. Prophylaxis: Preoperative: eradication of respiratory infections, stop smoking for 6 to 8 weeks for elective cases, breathing exercises, avoidance of dehydration, and avoidance of heavy premedication, especially with atropine and morphine. Operative: avoidance of deep unconsciousness and vomiting under anesthesia, trauma to upper air passages during intubation, and tight strapping and bandaging of the chest and abdomen. Post-operative: correction of dehydration, avoidance of heavy sedation, encouragement of deep breathing and postural exercises, removal of secretions by coughing, expectoration, and postural drainage, early ambulation, and adequate analgesia to reduce pain with coughing and deep breathing. And finally, if aeration doesn't occur within 4 to 6 hours, remove the bronchial plug by bronchoscopic suction. Treatment: try to expel the obstructing blood by turning the patient from side to side, percussing the affected side of the chest, encouraging expectoration and breathing exercises, suction, and loosening sputum by mucolytics, expectorants, and steam inhalation. Number 2, antibiotics to prevent infections. And finally, oxygenation. If oxygen saturation and oxygen pressure are low, intubate with mechanical ventilation. And this concludes our part for the cardiothoracic surgery for today.